So I am Lindsay Zimmerman. I am the Viral Hepatitis Prevention Director with Tennessee Department of Health. And for today's agenda for Project ECHO, we will have just our few generalized introductions and announcements. And then we will also have a discussion today by Dr. Mary Stewart David, or David, I'm sorry, I mispronounced your name. Oh, go back a slide, please. Okay. And that topic will include management of people living with HIV and hepatitis C co-infection. We will also have a couple of case presentations, and then as always, we will have an opportunity for questions and answer session. Also, please, if you have not already, register with the Southeast AIDS Education Training Center. That's the SEAETC. You can do that by using the QR code here or using the direct link. This will ensure that you receive your credit for attending today's session. You do have to attend the full session, and then you will receive a post survey via email at a later date for you to complete prior to receiving your certificate. If you have any issues with that, please reach out to Claire Bowles. Her information will be at the end of this session today on the very end slide. But if you do have technical issues with registration today, or even with joining sessions, or you have questions or comments, please reach out to Kimber Miller. She did drop her information in the chat, and she will be more than welcome or glad to assist you. And just a few introductions and announcements. As always, we like to see new faces and new names join Project ECHO. So if you've not already, please feel free to include your information in the chat, include your name, role, organization, and if this is your first ECHO session. So I'm seeing some very familiar names come through. Thank you guys for joining us again. Welcome, Banu. I'm glad to see you attend your first session.
Thank you.
All right. Well, please feel free to continue dropping your information in the chat if you would like. Also, please feel free to drop any questions as we start into our discussion. But I am going to go ahead and turn it over to Dr. Mary David, and she is going to discuss the management of people living with HIV and hepatitis C co-infection. Dr. David, please feel free to proceed.
Simple and treat their hepatitis C. Same
Hey, Dr. David, we're having a little difficulty hearing you. It's cutting in and out a little bit.
if that helps. And
that's better, right there.
Okay. Basically, technical difficulties if I have to do anything beyond that. I was initially asked to talk about PrEP and hepatitis C, and I said, that's so easy. I can do that in 2 minutes. You put them on PrEP and you treat the hepatitis C. And the only other thing is to watch out because they can get hepatitis C again. So I said, maybe wanted a little bit more than that. So I went looking. I feel a little silly because Dr. Chastain is the very first person who taught me about treating hepatitis C. When I said, wait a minute, I don't want just the people in the health department. I need to know this for my HIV patients. And for quite a while, I was online weekly with the equivalent folks from South Carolina, and they helped me tremendously. When I looked, no disclosures. I just disclosed everything. This is where I learned my stuff. And again, we are basically talking about treating hepatitis C the same way you treat anybody with hepatitis C. I don't feel like I'm a special expert there. Thing I've learned is just, unfortunately, you can get it again. So watch out. The same things that put people at risk for HIV put people at risk for hepatitis C. And we don't have a PrEP for hepatitis C, at least not at this point, or not that I could find. So I borrowed slides, went around the internet hunting the various AETCs, and these originated from the Mountain West. So we've adapted some of them. How do I change slides? Oh, that's how I tell you to. Basically, these are the same things that we use all along. Men who engage with sex with men, mono-infection, one infection at a time, co-infection, both of them. People living with HIV, PrEP, and antiretroviral therapy, those aren't new to anybody, I don't think. Unfortunately, the risk factors are same, so co-infection is the same. And it is one of those cases, everybody with either one should be tested for the other. About 15 to 30% of people living with HIV have co-infection. And the highest are our IV drug users. And people with hemophilia before routine screening, that's one of the things I'm ashamed of for the health system. We got treatment available for HIV back in 1984, and we did not start testing the blood supply until 1992. I think somebody should have gone to jail over that. About 5% have chronic hepatitis C and HIV because of those similar transmissions. Reviews, highest in Africa and Southeast Asia. Does that surprise anybody? Overall prevalence in MSM was 3.4%, 4 times as much in HIV positive MSM. This is the thing that I find appalling, and that is how few people are on PrEP and have been tested. We are not doing a good enough job of preventing. In HIV positive MSM, we've got almost 9 per 1,000 person years. So we need to be treating, we need to be following up, we need to be testing and making sure we treat as many times as we have to treat. The medicine works just as well. The problem is that HIV does accelerate the progression of fibrosis and can make it harder to clear. With my compliant patients so far, and as soon as I say this, I'll find one, I have not seen anybody not clear their hepatitis C. The whole thing is being compliant. It is much earlier in people in, the cirrhosis is much earlier in people who are co-infected. And our liver-related deaths in our HIV patients are because of hepatitis C. There is something that excites me now. We do now have approval to transplant livers from HIV-infected people to HIV-infected people. So that does help some with the access to liver transplantation. You can see how much faster progression is to cirrhosis, what we don't like to have happen. Before we treat, just like in somebody who is not living with HIV, we want to see how much fibrosis they have. We had for a while a FibroScanner, and I loved being able to do it here in the office. Unfortunately, when it got out beyond its initial period, and we were going to have to pay for it to continue to be serviced, we lost our FibroScanner. So we basically work with a non-invasive test. Liver biopsy can miss things, and it is just very difficult to get done. So we do mainly our laboratory evaluation, the same as with any of our non-infected patients. And medication, drug-drug interactions. Liverpool drug interactions checker is what I was taught as a go-to, and it's got HIV and hepatitis C drugs and interactions, and it is simple, it's free. Liverpool drug interactions is a wonderful thing. I've got it on my phone, I've got it on my computer. Definitely how we do check. As far as interactions that matter between HIV meds and hepatitis C meds, I have not had that limit my choice of drugs at all. SVR, you are getting the same or almost the same response with genotype 1 that you would get. We want people's HIV to be under control, so we want their CD4 count to be out of the AIDS range. And it's amazing how telling somebody you can cure their hepatitis C if they'll just take their HIV medicines can help with adherence. And I hope everybody, I apologize, my pronunciation of the generic names is atrocious. This was the first thing that was approved. We don't use it much anymore, simply because we do have better drugs now. But, oh, sorry. I am making a mistake in my generic recommendation. This is actually one of the two we use a lot. My patients like the fact that it is 8 weeks. They have a little harder time because they have to take it with food. They do a great job when they take it. We had some more problems with getting it from the drug company through assistance and insurance company approval with my HIV patients, but it works great. Like I say, I was thinking about another one. This is actually my go-to for most of my patients because it's one pill once a day for 12 weeks. And they can take it with or without food. They can take it at the same time as their HIV medicine or separate from it. and it works great. Like with everything, genotype 3 is a little bit harder to treat, but overall it works great. Lost a follow-up in one of my non-HIV patients. I had a young woman who had to run away from her husband and went to Mississippi, and she only got 8 weeks worth. And amazingly enough, when we did track her down, she was cured with that 8 weeks worth. So I was happy to see that there is a little bit of a window there that it works so well. And obviously, cirrhosis is going to be the time you have more problem. But we get good results overall, whether they've ever been treated before, whether they have cirrhosis or not. I think the difference between the no cirrhosis and cirrhosis turning out the way it does is partially because of patient motivation. If you hear that you've got cirrhosis already, my patients anyway are a lot more eager to get cured, and they don't have cirrhosis and they're coming in, they may have a little bit less, more of a laissez-faire attitude, and but still 94% success rate. And we basically see them back at 1 month, and then simply because they have HIV, I'm going to usually see them back in 3 months. But our gold standard is 3 months after that, and we're getting great results. They're equivalent. So in essence, this is our difference. Pan-genotypic, 8 weeks versus 12 weeks. And I think that real world data suggesting that 8 weeks duration is okay. 12 weeks is listed as an alternative in the opportunistic infection guidelines. But what we are doing is using it for 8 weeks because that is the real world data. And 12 weeks for soft bell. Our only problem is genotype 3 with cirrhosis, as far as the lenacapavir, perencervir. See, I don't do well with these names. Consequently, I do tend to favor the 12 weeks since I sometimes have a hard time getting genotype data. I have to go through some channels to get it approved for me to do that. Drug-drug interactions. This, where we've got our yellow, we worry about the booster raising levels if we're using the booster. We don't, because it will raise your levels of your hepatitis C medicines too. Really not in real life a significant problem with our soft bell. When you're looking at the drugs we use now, Cabotegravir is being used for PrEP, since we were supposed to be talking about that. The big risk with cabotegravir is that it is an injection and patients end up deciding they don't want it. It has a very long half-life and can hang around at levels that are too low to prevent HIV. And if that happens, then they get infected. There's a big risk of resistance to the whole class of integrase inhibitors, which makes me pretty hesitant to use it for prevention. That and my patients are notorious for not following up and showing up. But what we're usually using for prevention is either TDF or TAF. TAF can't be used in women. TDF can be used in women and is probably what we use the most and still works great as long as patients take it. And these are not significant drug interactions, so they don't have to stop their PrEP to take their HIV medicine, I mean, hepatitis C medicines. If we're doing any laboratory monitoring while they're on treatment, it's because it's time for their HIV labs. It's not monitoring the treatment. People on diabetes medicine should monitor for hypoglycemia anyway. We know if they miss a meal or something, they can get hypoglycemic. Warfarin, we are not using much. If we're just honest with ourselves, that's something we're not using much. But we do monitor for subtherapeutic anticoagulation, just like you would if they're having salads. Compensated cirrhosis, you're going to have to ask Dr. Chastain. I have not seen any problems with liver injury during treatment, but he has had a lot more real-world experience there. And we do our test of cure, SVR, at 12 weeks, just the same as we would with any other patient we were treating for hepatitis C. And PrEP, it's basically available for anybody who's negative. We're not going to try to prevent something that's already happened. It's, like I was saying, the tenofovir alafenamide and the tenofovir disprostyl fumarate. The big difference being that we can't use the tenofovir alafenamide for women at risk for sex. It presumably works just as well for women who are at risk because of IV drug use. But if you're protecting, you'd like to protect against both potential methods of transmission. It's very effective. Not the same as what we do when somebody has had an exposure. PEP is taken within 72 hours after exposure and is taken for 28 days. And it is actually a treatment regimen for HIV. Now, we've got two standards. One is for healthcare providers who get stuck on the job, and one is for anybody else out there. The maid who was brought into me because she was cleaning a hotel room and got a needle stick taking out the garbage. You've got 72 hours there. With those of us who are actually taking care of patients, we try to get them on medicine within 24 hours. And it is actually a treatment regimen. The idea being that if you get somebody on treatment that fast, you don't ever get a chance to establish the infection. We're not using it, whether it's PEP or PrEP, we're not using it for people who have HIV. It's strictly for prevention. And the fact is, you can get PrEP under almost all of the plans. One of the things we're doing routinely in our health departments when we do PrEP, because we usually have uninsured patients there, we go with the tenofovir desprostyl fumarate because it is a generic. We were doing prescription assistance through the drug company, but it is now generic. So if we need something that we can get through prescription assistance, then we will go to the tenofovir alafenamide. Looking at probably not some of the discount programs that are available, there are several. And if you actually go through them, you can usually get a month of PrEP for a patient for under $10, as long as you're using the desprostyl fumarate. And the patient assistance program works with the one that's still under patent, the tenofovir alafenamide. Common shared risk factors, co-infection. You know, if you're infected with HIV, it's probably going to make pretty much anything else you get worse. The two preferred, 2 pills a day for 8 weeks versus 1 pill a day, well, twice a day, versus 1 pill a day for 12 weeks. Both work well, minimal monitoring. They both really do play well with the first-line antiretrovirals. The thing you worry about with PIs is the boosters, and with the non-nucleoside reverse transcriptase, we're more cautious. But that's really not something that's involved with PrEP in either case, so it doesn't affect anybody who's not actually treating somebody with HIV. And like I say, I have Liverpool drug interactions. They've got an interaction checker for hepatitis C medicines, and they've got an interaction checker for HIV medicines. And I've got that on my cell phone in addition to on my computer. It's really fast and easy, free app. Questions?
So, Dr. David, someone has put in the chat, how are you getting the medication for PrEP paid for if they are uninsured?
In our uninsured patients, we usually, well, if they are male, we will go, male as opposed to MALE, we will go through the drug company. And their patient assistance programs really work well. Unfortunately, our uninsured female patients, I am getting that backwards. Our uninsured female patients are the luckier ones because they are going to need to use the desprostyl fumarate. And we can get, I'm going to break all the rules and use brand names for a minute because it is available only as a brand name. Descovy, we can use for men, but not women. So men, we will simply go to the Descovy, which is the more expensive of the two since it's still under patent, and we get it through the prescription assistance program. Women are going to have to use the tenofovir desprostrel fumarate, Truvada. And that one is now available generic. And while I'm using names, GoodRx, Mark Cuban Pharmacy, there's several of those that can get it for us for usually $10 or less at a pharmacy. Single Care is another one. But this COVID we get through patient assistance. It's not a problem. And they are great about getting it to us. The problem comes since the TDF is now off patent. It's available a lot cheaper, but we can't get assistance through the drug company anymore.
Thank you for that. So Jennifer has also put in the chat, what do you find is the greatest challenge, if any, in treating a co-infected client versus a mono-infected hepatitis C client?
I think I end up worrying a lot more about reinfection because my co-infected patients seem to have a harder time changing behavior. And that may just be the patients I am seeing, but it's not the drugs, it's not getting the drugs for them, it's the relapses, and it's the same thing I have a problem with treating their HIV. It's frustrating. It's amazing, though. I actually find that if I've got that carrot of I can cure your hepatitis C, it works wonderfully for getting somebody to be compliant with their HIV medicine, at least until their hepatitis C is cured. I've had a lot of things. It's an interesting side effect of the hepatitis C medicines. If you give them for 3 months, they can make patients disappear. I'm cured. They come back. But, that's the frustration for all of us treating pretty much anything. Any chronic disease is frustrating because patients get tired of dealing with it.
Thank you for those questions.
It's absolutely wonderful having a virus like this and being able to say, we can cure it. I am praying that someday we'll be able to say the same thing about HIV.
Yes, I agree. Just for the sake of time, we are going to go ahead and move into the case presentations. However, if you do think of questions as we're discussing these next cases, please feel free to include those in the chat. And then after case presentations, we can go back to the chat if we have time, and we can also address those